This podcast is for educational and entertainment purposes only. The views and opinions shared are mine and my guests alone and don't represent our employers, past, present, or future. Medicine is always evolving and practices may vary. Nothing here should be taken as medical advice. Always follow your own professional judgment and institutional guidelines.
Midlines have less infection risk than PICC lines or central lines.
Okay.
I think that's incorrect. Now remember, unfounded data, except for one of the smaller studies that have come out, have shown that there's very little delta between PIV and central line infections if you start looking for
And
PIV
delta has
infections.
changed.
Yeah, and the difference, here's why we see such a big difference between a PIV and a central line, is because we're counting central line infections. That includes PICCs. We're not looking into PIVs,
Right.
because we don't want to know. See no evil, hear no evil.
Welcome to the Beyond the Call Light podcast with Gary, the ER nurse, where we tackle the tough topics in nursing. Update your whiteboards and huddle up because this episode begins now.
Hello and welcome to this episode of Beyond the Call Light. I'm your host, Gary, the ER nurse. Joining me today is the Vascular Guy. You may have followed him on TikTok. He's got a pretty substantial following. I've learned a lot from watching his videos, and I was really excited when he agreed to come on as a guest on the show. So let's just get right into it. If you could just tell the listeners a little bit about yourself and your background.
Oh, hold on. Almost forgot. We're in a video format, aren't we?
Yeah.
No, keep it in.
Yeah, tell us a little bit about yourself and your background.
Yeah. I am the Vascular Guy. I had a previous past, and after that, I started nursing. Started in 2012 in hematology oncology. Very short stint there. Went over to traveling, and then did home health for pediatrics mostly. And then I went into the ED around 2015, 2016, and started my vascular access journey there. Got ultrasound trained, and then quit during COVID to do travel assignments. And a buddy of mine told me about this mobile vascular access gig, and been doing that since 2020. And now here I am doing whatever the heck I'm doing today.
Tell me, what does a typical day look like for you?
Gosh, now or as a vascular access specialist when I was working full time?
Well, do the vascular access when you were doing that
Yeah.
full time.
So specifically, I worked in the mobile vascular access team, and we had a couple different types of contracts. We had one contract where we stationed nurses at the hospital for 8, 12-hour shifts. And then most of the meat of our business was mobile. So I would get in my car, the company car, and then dispatch would send me and text me, hey, this nursing home, somebody's house, this hospital, this guy's work at the YMCA, like anywhere and everywhere that line needed to be placed, we get sent over all over. And I think we covered 1, 2, 3, 4, 5 states.
Wow.
So in the Mid-Atlantic. So we covered a lot of area.
Now, did you have like a portable ultrasound that you would carry with you?
Yeah. So I used we had a thing called the SiteRite, which is a BARD technology where they have the ultrasound and the intracavitary EKG tip confirmation tool. So you can do everything intraprocedurally all at once, which is very convenient. Big and bulky. And I found cheaper ways to do the EKG confirmation, and the Butterfly is what we used for a portable ultrasound.
Okay.
iPad, everything fit in a satchel bag smaller than some people's purses.
Yep. How does doing that mobile access differ from being like an IVT nurse or vascular access in a hospital?
Yeah, that's a great question. So I did that too, depending on what they needed me scheduling wise. So we would go there, clock in at whatever time, and we would start by checking the board. And on the Epic or Cerner or whichever, we would see how many lines were requested before overnight, basically, or over the weekend, depending on which hospital. So we see the list of needs, and then we would triage that need. So we would need to sit there and think and basically reprioritize that whole list of like, okay, which one's the most important and which one's the least important, and then we go from there. And this is why a lot of people get bumped, and people are like, where's the IV team? We called like 2 days ago. It's like, well, this guy was actively dying, so you got bumped down, and then this person's getting discharged today, so you got bumped down again. We have to reorient the priorities, and if there's a new case that comes in, just like the ED, we have to re-triage that line, and then now things may get bumped or moved up, and logistically also is an issue as well. We can't just go off of was it the ESI type of prioritizing, because sometimes logistics do trump patient's condition. Because if the patient's like, we've had this IV for a while, it's working, but they're in critical condition. We want to either central line or pick. And then there's this patient over here. So that ICU patient stable, but this patient is getting discharged today. And in fact, AMBO's on their way 2 hours out. I need to get this pick line in before they get here.
Right.
Is this patient stable? Yes. Hemodynamically and everything, the medications are running, IVs are working. We prefer pick line. Okay, we're going to have to prioritize and get this person out of here first, because worst case scenario, the ICU has resources for IOs or central line that the physicians can place. So they have resources. We may do it better, or it may be convenient for them for us to do it. But this, all that thing needs to be reprioritized. And then we go do our case, go back to the supply to grab the new set, look at our board again to make sure make sure our priorities are still good, then go back out. So it's a lot of back and forth, and that's where a lot of the time gets killed. And then of course the re-triaging each case is also where it kills a lot of time. So yeah, do that nonstop, go back and forth, patient to patient, back to the board, to the patient, to the board. And then of course, every time nurse calls, then we got to take minutes out of our day to do that, which can be important, but a lot of times it's just, hey, where are you? It's like, trust me,
we're working on it.
Yeah, so it's a lot of that. It's a lot of managing, and I'm not even going over all the cognitive, high level thinking we have to do, because once we get there, turns out, oh, what you asked for is not actually what they need. We need to escalate the procedure, or hey, this is way too invasive for what they need it for. So we're constantly re-triaging at every point of the care. That's where a lot of delays come in, is that we have to come in and kind of fix the indication or rationale to make sure the patient gets what they need and not what's convenient for the staff or misunderstanding of what the device does.
Now, what types of vascular access devices are you placing most frequently? Like first, like what types do you place, and then which one is the most common?
So in hospitals, we'd like to say the PICC lines, but probably volume-wise, it's going to be difficult PIVs. So peripheral IVs that were missed, or just patient was automatically a diva. It wasn't worth trying, because the nurses, which I give them credit for, the nurses didn't want to torture the patient, because they're like, we can't see it, we can't feel it, we can't even see it with the near infrared. There's no point in if I poke you, I'm literally going to guess at every angle and reinsert to see which angle I may hit the vein. And so let me not do that, and let me call the VAT team, and that's where we get called in. Second would probably be midlines and PICC lines, and then of course less frequent is central lines.
Let's transition to what you're doing now in the field. Like when you do the mobile stuff, what are the most common things that you're placing?
Currently, it's PIVs and centrals, and they kind of go back and forth depending on what kind of referrals I get. So I'm concierge now, and so patients call me and pay out of pocket for me to place their lines or help them manage their lines.
Walk us through the process when you're called to do like these difficult IV starts. So like you kind of touched on a little bit like the reprioritizing, but when you finally get to the patient, like what is your mindset? Like when you walk into that room, what are you doing?
First thing I look at the patient is, can they move, talk, walk? If they're incapacitated at any point cognitively, then I have to reassess, who do I talk to? The patient's not here. I need consent from somebody. So now I'm trying to read the room of, okay, who has the power of attorney? Let's say the patient is has full cognition. Then I need to figure out, okay, what are their physical limitations? That's just from visually looking at them. Then I walk in and talk to them and see how much they can comprehend what I'm saying. If they look like they're less educated or not aware of, anatomy, physiology, and just healthcare in general, I'm going to have to sit there probably for about 20 to 40 minutes explaining everything, making sure they understood what I'm about to do to them.
Okay.
And sometimes family translation, holy crap, if we need to translate, then that prolongs everything.
Yes,
So
it
I'm
does.
just visually quick look, quick triage of like, okay, what's the room look like? And then from there, I'll assess the anatomy to see, is what the provider ordered appropriate with the treatment, which I determined on the board during their chart assessment. And then from there, I look at the patient's anatomy and say, and determine if what they ordered was appropriate for the patient.
Right.
If it's not, then I have to basically walk back out the room, call the physician, and then collaborate on, hey, look, this patient's venous depleted. They're either going to need central or mid-thigh fem. And a lot of times they don't even know what that is. Like, you ask most providers what a tunnel line is, they'll know what it is, but they have no clue how it's done. It's like this voodoo magic that IR and surgery does. You don't see intensivists, you don't see ID, you don't see ED docs tunneling anything. And so because they're not familiar with the procedure, it's scary. It's like, no, that's reserved for super sick chronic patients and cancer patients. What do you mean tunneled? And what they don't realize, tunneling is the safest part of the entire procedure. But if you don't know what it is, you're cautious of it. And so now I have to explain that, let alone what the heck is a mid-thigh fem? No, fem, no way. The infection risk, no way. Okay, I said mid-thigh fem. Yes, it has risks, but significantly less than what we know as traditional inguinal femoral insertions. And so like all of that, I have to re-educate providers, nurses, and patients on what these devices are, what the contraindications are, what the implications are, and basically discuss and collaborate. Okay, so here's what's going on. Here's why it's an issue. My recommendation is boom, 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 boom. And then they fight back, and I'm like, hey, look, let's keep talking, because sometimes they'll bring things up that I didn't even consider. I'm like, oh yeah, if they already refused fistula, then who cares? Like, I can hit anywhere. I don't have to worry about nephrology and what they care about, because the patient already said I'm never getting a fistula. So it's a collaborative effort, and it's a consult basically, where I have to kind of let them know the situation, and then we have to sit there and figure out what the next step is going to be for the patient. And then of course the procedure, and then if complications happen during the procedure, then we've got to troubleshoot that. Sometimes I'll be in there for 2 hours trying to finagle a line to pass through the chest. Yeah.
Now, how has ultrasound changed the way we do vascular access and how we teach it?
Ultrasound took invasive procedures from the operating room, where only surgeons can do it, to now I'm doing it at bedside at the patient's house or at my house.
It's amazing.
It's crazy. It's crazy. That's the delta of safety that ultrasound provides. And I don't think people realize just how much of a game changer that is. So that's where ultrasound took us, and it's made it so much safer to do it. Now, the potential for safety, not actual safety. Look, you can give me a Maserati, you can give me a Lamborghini. I don't know how to drive stick. I'm going to crash into something, or I'm going to break the car, right? You can give me this great machine, this highly innovative, super performative machine, but if I'm not trained and skilled on it, I'm going to hurt somebody for sure, or something. Ultrasound is the same thing. It's this super high potential device, but if you're poorly trained, you're worse than someone who's blind sticking.
What are the most common reasons for IV failures, and like how can bedside nurses help prevent those?
I think one of the most common beginner insertion failures is we're prematurely advancing the catheter.
Right. Yes. Agreed.
And we have no idea. If you're not using ultrasound, for me too, I'm still guessing, because I didn't see everyone's insertion under ultrasound. I've only seen mine. And when I see the failure, I'm like, oh, no kidding, this is what's happening. So a lot of times we're prematurely advancing the catheter, because what we were told was, first you get flashback. What we were told is flashback guarantees you're in the vein. That's false. Flashback guarantees that your bevel is in the vein, but it doesn't guarantee that your catheter is in the vein. The 5 years that I've been in the ED, the years before that of doing other work, I've never looked closely at the needle bevel tip. I've seen the bevel, I kind of looked at it, but I never saw that there is a bit of a separation between the bevel proximal end and the catheter.
Right. Yeah.
And until you actually look at it with a earwax camera or microscopic camera or macro lens, you're not going to see that. What I've realized is when we tell people flashback then advance, we're telling them to advance too premature. It works 50% of the time. Again, I'm making these numbers up. However, the other 50 is because we're not putting in enough. And so that's why the new technique that a lot of people are saying now is after you get flashback, you want to shallow out the angle and then advance a little bit more to parallel to the vein, and then you advance that catheter. Another is back walling, of course, going through and through. Case in point, we're testing out our competition in our device, and one of the inserters, they kept missing both veins of our boss. But what we didn't realize was that the vein was way too small. It looked like, oh, I can see it. I can definitely hit that. And she got flashback. However, she wasn't fully in. And when I assessed the vein afterwards with ultrasound, it was a pinpoint 2 millimeter size vein. Very small, inappropriate for a 20 gauge. And we're like, why did it fail? I'm so good at this. The vein looked very visible. So they're unaware that the vein is actually too small for that catheter. That 24 gauge catheter was the one that we were supposed to put in, and it would have succeeded that insertion. But we did it because, patient already got their CT scan. They don't need another one. Patient is not here for fluid resuscitation or, massive rapid transfusion. But I still wanted to put that 20 gauge because I didn't want to be a little bitch. 100% ego. And so that insertion should have been a 24 gauge, not even a 22. And so again, we're picking bigger than we should catheters for smaller veins. And so those two are the main reasons why I think we're failing on most of these blind sticks.
What is your thought on the number one reason for failure for ultrasound guided IVs?
Number one is we don't know where our tip is. People cannot and have a hard time identifying their needle tip. For me, how I train and how I practice is if I cannot see the needle tip, I don't advance the catheter. Sidebar, what is considered one attempt? What did they tell you?
As long as that needle is still in the tissue, that's one attempt.
That's so the reason why they told you that is because they want you to feel good. It's an ego protective definition. Why do we even care about attempts? What's the rationale for capturing that data?
I think cost is definitely one. So every attempt where we use equipment, that's an additional cost. I think I priced it out. It's like $25 for every attempt with a straight, like just doing a non-ultrasound guided. You add ultrasound and then it adds to that cost. So I think there's a cost element to that. I don't work at a hospital that is super concerned about that. It's a federal government facility, but for-profit hospitals are very concerned about where you have to scan everything. Like you can't even get that stuff out without scanning the patient's barcode and then matching the supplies to them. So I think there's definitely a cost element to that, but also there's obviously patient satisfaction scores. The more attempts we do, usually the worse experience they have.
My mentor, Dr. Jack LeDun, he gave me this definition. He said, you're not going to like it. One attempt is considered advancement enough to puncture tissue, even subcutaneous tissue, every time you go forward. Every time the needle moves forward is an attempt. Okay. Why? Because clinically, we're trying to measure what was the risk of damaging the patient unintentionally. What was the risk of perforating things we didn't want to perforate? Pulling out the needle is not the problem. It's going forward with it that we can hit things we're not supposed to, or that we unintendedly, like arterial nerve bundles. And so that's one attempt, but nobody wants to measure it that way because it is so difficult. This is why when I measured it that way, I was now more careful about making sure that the trajectory of my needle tip was going the right direction, and I moved slower.
Right.
Because I was like, I don't want to chart second attempt because I had to do this. I just want to go forward once, and that's it. And that's that difficult acceptance of that definition made me a better inserter because it forced me to make sure I wasn't BSing or bullshitting my needle direction
Right.
Guaranteed I'm going to get it right. I'm not going to screw this up. Let me make sure I know where my needle tip is. So that's the number one thing, not knowing where your needle tip is.
And I track every single one I do, and critique and everything like that. But one of the things I have really learned, slow down. Like I get that initial poke just to get over that shock for the patient. And then it is literally, we are finding it. We're advancing, we're finding advancing. And I've got to the point, like when I started doing midlines, you would get a patient, they don't have a cephalic, the basilic is not an option or is non-existent, and your only option is that brachial vein, which is right next to your brachial artery. And I wouldn't even touch that because I was like, I don't feel comfortable. But as I've gained more experience with that slow approach, if that is my only option, I am much more confident accessing that now because of that going slow approach. And I think that is what, and so when I'm teaching somebody now how to do ultrasound guided, I teach them the slow approach. If you don't know where your catheter tip is, that hyperechoic focal point that you see on your monitor, if you don't know where that is, you might as well blind stick them because that's exactly what you're doing.
Well, here's the thing. I think a lot of times, especially in the ED, we rush through it because we're like, oh, I've got 100 things to do. ICU, same thing, everywhere at med-surg. What we don't realize is if we miss, how long is it going to take to do another insertion? You got to re-prep, re-gel, recover. Sometimes we skip that. Remember, at the detriment of the patient, we skip it to work faster. But these are the things that we're supposed to be doing. Find another site, rescan that other site. So the time it takes to restick almost more than doubles what you're going to need to do for the first stick. So might as well just get it done right the first time, even though it's going to take you a little bit longer.
And I would add to that, one of the things that I've gotten in the habit of doing is I will look at both arms. Even though I see like, oh, I think I can get that, I will go to the other side. Too many times I've missed that one and I had to go to the other side and I'm like, oh my gosh, like a beautiful cephalic, straight. I could have nailed this on the first try. So I've learned the hard way to look at both arms and find the best option before you just go stick it. Don't stick the first thing you see. You need to find out what your options are. And I think that's really helped my patients reduce the number of sticks that they've required. And it's also definitely improved my percentage. Let's talk about myths and misconceptions with IVs and maybe the more difficult like central line placement or midline. So what are some of the myths that you frequently encounter with regards to cannulation?
The insertion process itself, the number one thing is if you see flashback, you're good to advance the cath. That's the number one myth. Here's a controversial one.
Okay, let's have it.
Now, the data that's out there is proving me incorrect, but the data that's out there is also garbage. Let me explain.
Low quality?
Terrible quality. So let's say midlines have less infection risk than PICC lines or central lines.
Okay.
I think that's incorrect.
Okay.
Now remember, unfounded data, except for one of the smaller studies that have come out, have shown that there's very little delta between PIV and central line infections if you start looking for
and
PIV
delta is
infections.
changed.
Yeah, and the difference. Here's why we don't see that, or why we see such a big difference between a PIV and a central line. It's because we're counting central line infections. That includes PICCs. We're not looking into PIVs.
Right.
Because we don't want to know. See no evil, hear no evil.
You're listening to Beyond the Call Light with Gary, the ER nurse. If you like what you're hearing, make sure to follow and subscribe on Spotify, YouTube, Apple Podcast, or Amazon Music. New episodes drop regularly, and your ratings and reviews help us reach even more listeners across the healthcare community. Now, back to the show.
So
you can't
now
have
that people
can't have infections if you don't track them.
So here's another myth that kind of correlates with each other. The myth that the CMS will not withhold reimbursement for a peripheral infection, a peripheral IV infection. People don't believe in that. You're dead wrong. Here's why. There are multi-billion-dollar companies that are lobbying CMS
It happens
to, I'm
every day.
make sure that they make those rules and set those rules in favor of the company, I'm sure, but also so they don't screw it up like they did for this CLABSI initiatives. The CLABSI initiative, the central line bloodstream infection initiative, to try to curb the infection rates, made people find shortcuts that was detrimental to the patient. Because of that, now patients are suffering without the hospital paying for it to avoid that CLABSI ding. And
Now,
collapses are very.
do you have an example of like where you say they're cutting corners? Like, do you have an
Oh,
example of that?
Why are there so many midlines being ordered when a PICC line or a central line is more appropriate? Hey, doc, they're running vesicants. It's going to F up those veins no matter what. Why don't we just put in a central line? Why
Okay.
not?
Is it more expensive?
Because
Or is
well,
it
no,
because
no,
of
no.
the because of
the risk of infection for the by
Okay.
golly, for the sake of the patient, we don't want them
Right.
to get an infection. That
Right.
is a good thing to be concerned about. Don't get me wrong. I'm not knocking down the seriousness of sepsis. However, why not a PICC line? It's because we don't want to get dinged for that CLABSI, and we don't trust our staff to keep that infection from happening. Remember, these line infections are us. We're causing it. And the reason why we're avoiding it is because we don't know how to stop these infections from happening. Now, I have a good idea after all the things I've learned over the last 4 years. However, it's hard to change habits. But the myth is, oh, that's never going to happen. There are multi-billion-dollar companies that are lobbying with CMS to make sure that CMS does not screw up how they screwed up CLABSIs. How much does it cost to pay a lobbyist? Lots of freaking money. I've seen the lifestyle they live. We're talking lives way above average means. That's how much they're paying to make sure that CMS doesn't screw up this thing called HOPSI, hospital-acquired bloodstream infection. Now, they're not going to care where it came from. If it happened in the hospital, no matter what it was, we don't care if the patient stubbed their toe and they got the infection and it happened at your hospital, you're getting dinged for it. So they don't know that's coming. But now that some hospitals are hip to that movement of where CMS is going, they've been watching and paying attention to PIV infections, and they've discovered it's not as innocent as we thought it was. Pseudomonas, staph, all these surface microbes are actually being in the body. It's from these PIVs.
Interesting. Now, and that kind of rolls into my next question was how do you stay up to date on all of this information? Like where do you go to get the most accurate information for vascular access and infections? Like, where do you get this information?
So SHEA, SHEA is where you want to get your information about infection control and risk. And AVA, AVA is going to be about the vascular access procedural type, but also indications for the catheter. And then Infusion Nurses Society, INS, would be where you get your overall picture. Now, be careful because each society has their agenda. Each standard practice has their agenda. So you have to make sure and think critically, okay, yes, this is what it says. And during a lawsuit, when I get sued, these bodies of works is what they're going to fight me against. So when I deviated from these recommendations, I need proof of my own that I have better evidence, or that standard of practice did not apply to my situation.
It's kind of like up to date. Like if you say, "Hey, I followed what up to date said," that's kind of like your legal fallback.
But I can't vouch for up to date because I've never read anything from up to date, so I don't know what. And I'm sure they're getting it from the source, which are these societal guidelines. Yeah.
Right. So our hospital uses up to date. So like when a physician has an infection or whatever, they can look up like, this is the infection and these are the recommendations, and they can go, well, I followed the recommendations. Like this is what the current evidence suggests. So that's what we went with.
And remember, up to date has their own agenda. Who uses up to date, physicians or nurses?
Well, mostly physicians. I do use it as well.
So it's going to gear towards physicians.
Correct. Yeah. It's geared to them.
So let's say, and the reason why I bring this up is we have to be careful of the evidence that we read. There were studies showing that midlines are safe to use for vesicant medications. I've seen those studies. I got to read some more of them. Why is it okay for midline, but not okay for PIV? When a midline pretty much is ends up in a peripheral vein.
It's just a little bit longer of a cath.
How does a catheter affect the damage of a medication? So these studies don't specify where the midline is being terminated. Okay, so for I'm sure you were taught midline is anything shoulder and down, right?
Yeah, like basically elbow to shoulder.
Yeah, so that's the American definition. And the new definition in America, which needs to be changed, but that's a whole nother like study by Marsha Ryder, or analysis by Marsha Ryder. In Europe, and how we used to do it was you terminate here. past the clavicle and this into the subclavian or before the subclavian. So this whole region was where the midline was considered. And for a lot of us, that's still where it's considered. In Europe and before this lawsuit, we used to terminate around here.
Okay.
Now, there was a lawsuit of a pilot that he won. I think he was awarded about like $7 million or something like that. The blame was on the catheter tip location, which is true. The catheter tip location was suboptimal.
Okay.
But when you take a look at the lawsuit, there was neglect from the beginning of the insertion all the way till them telling the patient, "Go F yourself. We're not going to apologize." That's when the patient said, "You know what? I'm going to sue you now."
Time to lawyer up.
All he asked, change your policy, apologize publicly, and they said, "No, we're not doing that." So that's how it turned into this major lawsuit. So all the way from inserting at the elbow, from insertion, it was just bad practice all the way through. And the patient deserved it because we were gaslighting the patient into telling him it's normal, don't worry about it, when he was developing compartment syndrome under that clavicle. So because of that, instead of addressing the negligence of the clinicians, we blamed it on the catheter. And we said, okay, the catheter tip, it's too dangerous. We're too stupid to monitor properly. Obviously, from this lawsuit, we're too stupid to even manage a line in that location. So to be safe, we're going to now terminate here, because if you F this up, at least we can tell before it gets really bad. So that's why we said to terminate here. But evidence is showing that it is better to terminate lateral or medial to the clavicle itself. As long as you're not terminating under the clavicle, these are the optimal spots for midlines because they offer more hemodilution. If they do, which a lot of times, if you take a look at the chest, you're going to find out these are very, very tiny veins. We're going to need a central line anyways.
Okay. All right. Ultrasound is obviously a wonderful technology to have at your disposal, and it has served us well. Especially, we get a lot of dialysis patients who are very hard sticks or who have missing limbs, and so that has come in very handy. But not every facility has access to ultrasound or people that are trained in how to use it. So for hospitals like these smaller hospitals without a dedicated VAT team or vascular access team, what can bedside nurses do to improve their practice in obtaining IVs, peripheral IVs?
Before we get into that, I want to touch on another myth that you can't use the fistula for IV medications. Vancouver, Canada is now using ultrasound guided IV insertions to use the fistula to give medication treatments. Not every medication, but non-vesicant, non-irritant, you can go ahead and use that. Or at least they were using it and they were successful in keeping the integrity of that fistula.
Interesting.
So going into PIVs, if you don't have ultrasound, what is the best optimal solution? It's going to be that flashback, shallow, and advanced is going to be your best bet when it comes to successful insertions. If you cannot see it, if you cannot feel it, that to me is a diva patient. I don't care about their age. I don't care about their disease. I don't care how much money they have. I don't care where they work. I don't care who their daddy is. If I can't see it, I can't feel it, they're a diva.
And I feel like I got to clarify here. You're saying diva. I know what that means, but I don't know if everybody else knows. So when we say diva, we're not talking about like patients that think they're better than everybody else. We are referring to
patients, difficult IV access, DIVA.
It's just an acronym we use. We're not judging the patients here. We don't do that here.
No amount of PC warriors will ever stop us from calling people divas.
Well, I mean, that is the clinical term.
Okay, so PIV in an extreme case, and I would only trust high-level inserters and providers to do this. You can do if you find something in the hand. I've heard people do this. I'll never get a chance to do this because I'll never be in a situation where I don't have an ultrasound for an insertion. Even in Haiti, I have my ultrasound. Like the butterfly goes everywhere with me. Guatemala, like I have no excuse. But worst case scenario, tap the hand, inflate it with saline. I couldn't tell you the protocol, but I've heard people say that they've inflated the veins with saline by applying a tourniquet up here. So choke up the return blood flow and then reinflate the veins with that saline. Now, what's the safe infusion rate? What's the amount of pressure you need to apply? What are the contraindications and side effects? I don't know. I'm just sharing ideas and things that people have tried at worst case scenarios, or you IO them if they're dead. How imperative is it that we need to give them a high flow rate or vesica medications?
Yeah, an emergency department, like
So-
if they need it, then we'll definitely place it. But for those patients that come in and like, oh, I'm a hard stick, you can't see my veins. What about like techniques like doing the double tourniquet, warm compresses? Is all that bunk, or is there
you can do all
something
that.
to
I'm
that?
sure people have heard that one. No, there's definitely something to the double tourniquet, and here's what people don't understand about the double tourniquet. It's not tourniqueting anything extra in your superficial veins. It's tourniqueting your deep veins. So what it's doing is it's applying compression, and it's applying extra compression to stop that deeper vein from flowing. So let's say for the superficial cephalic, cephalic, your posterior basilic, and maybe even your basilic is choked up, but your brachial's not. So all that flow is going to get deviated to your brachial. What the double tourniquet is doing is not, I don't think it can choke up it may, depending on how tight you make it,
Right.
but you're just compressing a little bit here, and then again, a little bit here so that you can really slow down that blood flow. That's really what that's providing. If your initial tourniquet, your one tourniquet is doing that, that's fine. As long as you're choking up the blood, the return flow
Right.
at your veins. So you can use a blood pressure cuff, which I think can provide more compression. Another trick that I've seen that I will never use again because I've ultrasound is if they're edematous, just pit their edema, and then hopefully the veins will pop out a little bit better for you. Because the problem with the edema is that the skin is so far up, and you just compress it to where the vein is, closer to the vein, and now you can feel it, maybe even see it. So pit that edema. The problem with that is if you don't have a long enough catheter and you're like, oh, I got it. What happens when that edema starts rising back up?
It's going to pull that catheter out.
Catheter is going to pull out of the vein. It may have stayed in the skin, but it won't stay in the vein. So just be careful. Most of your IVs are probably too small for that technique. But if you need something now and you don't care that it blows in like literally 2 minutes because you want to use it now, then that's one strategy you can use. And this one, look for this.
The back of the forearm.
A lot of people miss this one. I've been called in, and we get paid really well for mobile vat to insert per line. And so they're like, yeah, we can't find one. I'm like, oh man, this is tough. And then I look back here, I'm like, holy crap, you fit an 18 in that one. And so look back here in the posterior basilic, a lot of people miss that. And it is difficult because then you got to like finagle your body to like, how do you,
it's a very awkward angle.
Yeah, it's a weird angle.
And I'll actually caution people, if you decide to do that, be careful, because I have seen 2 people in my career access that in the wrong direction because they get so turned around.
Because they go this way.
Yes. So they actually put it so the catheter is running toward the hand. So whenever I see that, I'm like, just make sure you're oriented. You need to always be going toward the elbow. That bevel needs to be pointed toward the elbow.
Yeah, and the retrograde is no bueno. I'm actually editing a video. I did it to a patient. We were all out of options. Like literally, I need to put a tunnel line in her. And so we tried the retrograde because I've seen some studies that showed efficacy and longevity of the dwell time. I'm like, oh, that's interesting. Gave it a try. I highly do not recommend that because she immediately thrombosed. Like seconds. I did not know you can develop a thrombi this quick. It was instantaneous.
That's wild.
Thrombosis development from this retrograde flushing. So don't do it. Okay. It's not good for medication administration. I'm sure the study had like great catheter to vein ratio. But the reason why we're doing it, these weird techniques, is because patients has crappy veins. That's and so they're not going to be in a good situation. So yeah, this is why you don't just read a study, you have to dissect it. Going back to that midline thing, a lot of those studies that say vesicants and pressures are okay and safe for midlines, we're terminating at these locations, basically a central line. We're terminating at these locations. Now, what they didn't go into was how long they were able to keep it without screwing up those veins up here. If you're not able to read these at a high level, let me not say that, because I want to give people the encouragement to read, because I see a lot of these people posting, if you don't know an RCT or a P value is, you shouldn't be reading. Like no. That's the wrong way to talk about studies and intelligence of reading these things. Go ahead and read it.
But the more you read,
Bingo.
The
Like,
more you'll understand the next one.
bingo. Do it. Read it. But just know you have to be skeptical. Look at all the angles because there's a lot of things missing in there that you may not understand has a significant impact on the outcome of the results.
Thanks for tuning in to Beyond the Call Light. You can catch every episode on Spotify, YouTube, Apple Podcast, and Amazon Music. Follow along, share with a colleague, and join the conversation. Speaking of which, let's get back to it. I have these Facebook groups with different EMS and through healthcare, and they'll post a study and be like, oh, this is so exciting. And there was one that was like doing CPR in a semi-Fowler's position. And I was like, what? So I read the study and I come back and I'm leaving comments like, this is a very poorly designed study. There are so many conflicts here. Like the author of the study sells equipment to do the CPR. I have an issue with this. And then not like a week later, they retracted it because of all the issues with it. So, I mean, it's one of those things. Am I the world's expert on reading? No, like I'm not a researcher, but I know enough when I read it. Like that's one of the things they teach you in nursing school, how to read these studies. Yes, p-value, all that stuff, but go to the bottom and read the conflicts because that'll tell you a lot about a study. So yes, you're right. Do not be discouraged. Read the studies. You don't have to be an expert. The more you read, the more the next one will make sense. So yes, we are on the same page with that.
Just to reiterate the fallibility of the vascular guy. Like I read a study about his mechanisms of peripheral IV. It's so long and engineer heavy that I can't even recite the whole title. I misread that study as the insertion angle. The higher the insertion angle, the decrease in dwell time you're going to have, meaning your catheter is going to fail faster. The higher your angle of insertion is how I read it. But what it was saying wasn't insertion. It was rest, angle of rest. So in your vein, the higher, if you look at the ultrasound and you see your needle or you see your catheter sitting like this instead of this, the higher your angle that it's sitting in your vein, the more likely it's going to fail.
Interesting.
But I misread that because I had my own biases of, I know anecdotally that the higher insertion of angle, your catheters are going to kink. It's going to fail for various reasons, endothelial injury. And a lot of other experts agree with my sentiment, but there's no strong data supporting my statement. Okay. And so I thought I found the key to supporting what I initially thought, but I was wrong. And someone called me out for it. And I was very happy to make multiple videos about how wrong I was. But even I can misread things. And even what I say as an expert, you have to look at it skeptically and check the evidence like a lot of my followers are doing, which I really appreciate. It just makes me smarter. So yeah, even the experts online, even the experts that are on speaking at the podium, there are people who, even in my specialty, they're like, oh, she's like the godmother of vascular access. I'm like, okay, cool. She's wrong in a lot of things that I talk. Like she's going off of studies that are like, what, 10 years old, and she hasn't read the one in 2024. So, and she's citing these older biases of her own bias of this practice that she says is dangerous, where I have evidence currently with engineer level data to prove that the safety and efficacy is there. Again, we have to read it for ourselves. Yes, listen to the idea, let the idea actually be introduced, but vet the information before you start doing anything for your patients. Yeah, a caution to everyone watching my videos, like I'm fallible. I'm not going to give you all the 100% perfect data. I'm going to try for 100%, but if I'm incorrect, you guys need to be aware that I can still make mistakes.
When new nurse graduates or new EMTs come along and they ask for advice, the one thing I tell them every single time, trust but verify. So you're going to have clinicians that are going to tell you things, right? And you're going to see them as somebody with experience. So you're going to take what they say at face value. And I say, don't do that, because they may not be up to date on the latest evidence-based practice, and they may be using old information or completely incorrect information. So trust, but verify. So yes, I will take the information that you're giving me, but I need to go verify that because it's my license on the line and I need to protect that. So yes, trust, but verify. Let's talk about innovations in vascular access. What is something in vascular access that you are excited about right now? Whether it's a new catheter, new materials, new techniques.
I'm excited for our company's products, but let me hold off on that. Other products that are out there, there's this nasal cleanser that has shown a reduction in collapsy. If you sanitize your nares, it'll reduce infection rates. Basically, this will reduce the infection of your lines.
Interesting.
Yeah.
Is that just because
crazy.
people Is it because people are just so used to touching like their nose and their face and then
So the
messing with
assumption is
things?
the point of our nares and the hairs of our nares is to catch all the microbes and all the junk before it gets to our lungs. So they found that if we sanitize that area, it helps to reduce the infection risk. We don't know the actual causation, we just know the correlation, and it's
Okay.
pretty strong.
Okay.
And so they found that all they did was change that wiping, that Nair not sterilization, but cleansing, and they found a significant reduction. That was I think that was the only thing they changed. I have to again double check the data, but they found significant reduction in collapses, enough to start selling the product. That's blowing my mind. That indicates to me that we are breathing, exhaling bacteria into the area that we're working.
Which is
Yeah.
one of the reasons that like when we do ultrasound guided IV, particularly my practice has been I wear a mask for any ultrasound guided IV.
Yes.
But I've gotten so used to with the midlines, you have to wear one. But I've gotten in the habit of just wearing one when I'm doing that, just to help decrease that risk of infection. Now I'm really glad that I do. I saw somebody post something on, it was one of these ads on TikTok where they were swabbing their nose with what looked like betadine, like providone iodine. And I was like, what is happening here? Like, what are we doing here? And I was like, that's not a thing, is it? Like, we don't do that in hospital. I've never seen that done. So I had to go look it up. And I was like, oh, so they do that. Like in OR, for OR prep, there are cases where they will do that to help reduce the risk of infection. And I had never seen that before. And I don't work OR, so I don't deal with that. I mean, I will swab a patient who's admitted, like for MRSA, where we track that data, but we don't clean their nose. But I learned. And then now you come on here telling me that that's also a thing. So now I'm like, okay, trust but verify.
Yeah. Next thing is gonna be, hey, if we wipe your butthole, it'll actually eliminate infection. That's a joke. That's a joke.
That's a
There's no
joke.
data. But yeah, that needle-free blood draw, of course, our thing. I'm biased because we
Right.
make it.
Whoa. Needle-free blood draw?
Yeah, baby.
Tell me more.
So check this out. A little shameless plug.
Go for it.
We have a device that can piggyback when you have a PIV catheter, we
Mhm.
already have access to the vein.
Correct.
So let's put in a smaller tube that goes in through the catheter, draw blood, and then now you can keep using your PIV.
So why not just pull it off of the PIV?
Have you seen a fibrin tail?
So yes, where when you flush, you can see that little clot on the tip of that catheter going out.
So that fibrin tail, that basically, I call that the fibrin foreskin. Basically, it's a tube. It's a fibrin sheet that was wrapped around the catheter.
Mhm.
Basically, a tube form. It's almost like it was like a balloon. And then when I flushed, it dragged that tube out to the tip of the catheter. It's fully patent. There's no thrombi developing.
Right.
I can still use that PIV, but I definitely can't draw blood. Okay, we got to poke the patient for it.
Okay.
And a lot of people are drawing blood incorrectly from the PIV. That's why there's studies showing increased hemolysis rates with smaller catheters. Now,
Is it just because the turbulent flow coming back? Is it like hemolyzing the samples?
I think most of those studies are not taking into account the most important thing, which is negative pressure applied. Those studies, I think, are erroneous. They are correct in showing the correlation, but they're not showing why, and it's not
Causation.
a solution. Right. So it's not a study to fix the problem. It's a study to tell nurses stop doing it because you're costing us millions of dollars from wasted labs.
Yeah.
And time. Not only did we waste the patient's blood, 13 mLs, but we had to send it to lab, waste lab time. And also, if we do run it and it came out erroneous, now we wasted whatever it cost to run that. And so it became so financially unfeasible. They just are telling nurses, just don't do it because we don't know how to fix this issue. You don't know how to fix this issue. So just don't do it. Get a fresh puncture. But what truly I think is happening, again, theory, because no one's actually tested this out there's no RCTs done on this kind of study. So I would love for someone to pay for it. And there's no financial incentive for anybody except for hospitals. I think because of the smaller diameter syringes and because of thrombis developing around them and because they're not even in the vein properly, it's called cavitation. We're cavitating the blood. If you ever dive, you know that if you rise too quickly from underwater, deep sea, and you go up too quickly, you're going to die from an air embolism, nitrogen poisoning, nitrogen gas poisoning, blah, blah, blah. It's because the bends, you're literally causing the bends in that patient's blood. you're benzing the patient's blood because you're
Interesting.
quickly applying that negative pressure, holding it, hoping that it'll come through. It's trickling in, but your
Yeah.
negative pressure and the vacutainer's negative pressure is
Yeah.
causing the bends to happen to that blood. Now,
Interesting.
the reason why the vacutainers still work is if there's patent blood flow. But if
Mhm.
you're popping it in and there's like trickles of blood, that high negative pressure is still maintained. You haven't equalized it because it didn't fill with blood yet.
Correct.
That's why we're hemolyzing these samples with smaller gauge catheters. But if you got an interflow tube that goes past all that issue, then now we can draw blood without needing to waste
Yeah.
and without needing to poke the patient a second time. It does not work for every patient. If you have a thrombi develop, you can't use it. You can't go
Okay.
past a thick thrombi. There's no way. Or let's say you have a high angle of insertion, like it's literally the catheter is resting like this in the vein because of your high insertion. Then it's not going to pass at that high angle.
I'm trying to think. So we use Nexivas, right? So Nexivas, I can't disconnect from the hub. Now, like a Gelco, like you can separate that J loop or the extension tubing and access that directly. So does this work with everything?
That's a great question. With those integrated, they have their own versions. I think it's called the Nexiva Pro. Don't
Okay.
quote me on the name, but they
Yeah.
have versions that you can ask them for. Hey,
Mhm.
look, because they have a needle freeze. It's basically similar technology. They have one themselves where if you get the more expensive Nexivas, you can use it. So it's got like a side port that helps them to pass that interflow tube. Ours works with anybody. The only caveat is you have to use a split septum T-piece connector.
Okay.
And so if you have that, we're compatible with any IV, any T-piece split septum that exists
Oh,
out there.
so you don't have to like you don't have to like disconnect the hub. You could actually just go into the existing port. You just got to take
Right.
that little
But you have
cap
to have
off.
but you have to have a T-piece split septum T-piece port.
Okay.
Which a lot
Okay.
of people don't have. So we
Right,
offer
I'm-
that as well with the packaging. Yeah.
Nice.
Yeah. So there's a lot.
Yeah.
So it doesn't work for everybody.
Right.
We still have, you can still hemolyze.
Uh-huh.
We've only had one sample that hemolyzed, but that's because the catheter, we found out the catheter kinked on the
Okay.
inside. When we pulled it out, it was all mangled. So
Is
we're
it-
like, oh, okay.
Is it one diameter? Is it like just what's the diameter of the one that you put in there?
Ooh,
you slide
I
in?
don't know, but it fits. So we have one for 20, 22, and a 24.
Okay.
And so
Oh,
it'll
wow. All the way
fit
down to
in-
a 24. Nice.
So we're really excited about not sticking kids as much as we used to.
Right.
Or
Oh,
we
gosh.
are currently. So that's the excitement here. And from our internal data, of course, it's biased. So we need, third parties to test this out. But
Right.
the reason why I'm happy to join the company is because I tried hemolyzing the sample by yanking on that syringe, that 3cc syringe, as hard as I
Mhm.
can. And it flowed slowly. And I was like, this is going to hemolyze. Sure enough, for whatever reason, it didn't hemolyze all 3 samples that we pulled. And I was like, I need to figure this out. And
Yeah.
the engineers and I are still trying to figure it out, but we're like, this should have hemolyzed and it didn't. This is awesome, but we need to know why it's not. So there's a lot more to investigate here, but so far the preliminary tests have shown very, very promising samples. We have to waste their blood for these PIV blood draws,
Right.
because the samples are tainted with coagulation factor, coag factors, factor whatever is sitting on the tip of that catheter. There's going to be thrombi developing over time. And so we have to waste for coags.
Yeah.
And so there's a lot of reduction in blood waste for patients with both ours and the competitor device. I'm excited regardless of what I would love for people to use ours, but I'm happy in general that this technology exists for us and our competitors so that our patients can suffer less. So the technology itself is exciting.
All right, so a couple more questions and we'll wrap up.
Yeah,
what,
bring it up.
what do you wish more people understood about vascular access and like ultrasound guided AVs? What do you wish people, both on the patient side and in hospital?
Let me start with this. Because we as clinicians feel like we have no other solution, we are accepting patient torture. We are accepting poor patient outcome. We are accepting poor practice in general because we're like, I don't know what else to do. I don't know about the technology that's out there. I don't know about the different skills, or we're refusing to adopt the technology and the skills. So both of those things, I think, are the root causes of every poor outcome in vascular access. All the bad things that patients are having to suffer through from our hands is because of those two things. If we can attack and accept it and look for it, then I think we're going to find some really cool things to help prevent our patient suffering.
I would agree with that. One of the things I've really pushed for is really encouraging my nurses in my emergency department. If you have a patient who comes to you and says, I'm a hard stick, do you have somebody that can do ultrasound? Don't hesitate. Come get me. We can improve like patient outcomes. We can get them seen, treated faster, and we can reduce like the stress on them. So, and they have responded. Now I do have a couple of older nurses and I joke with them. I'll say, hey, did you bring your vein finder today? And they'll go, never leave home without it. Now, to be fair, if I had to pick, there's two nurses on my tour that are very experienced nurses. And if my family's life was on the line and there was no ultrasound, they're the ones I want, because like their success rate is like astronomical. They find stuff that most nurses would never even dream of. I had 2 consecutive days where both of them came to me for an ultrasound IV, and I was like, I need to write this down in history. So even they're recognizing that there is a benefit to this. So, but yes, we need to change people's perceptions and think about our patients, because that is ultimately what we're here for.
Until I came into this vascular access specialty world, I thought I was hot shit. 'Cause in the ED, I got 100 consecutive patients first stick success. I was able to get that in the ED when I didn't know what the heck I was doing. And I came into it like, oh, I'm pretty damn good with the ultrasound. Yeah, train me on PICC lines today. I don't need that midline bridge, right? What I didn't realize was 100% first stick success should be the standard. I'm at that point where I don't count my successes because it's too many. I count my failures now.
Interesting.
Because that's how little I fail in a year. In fact, since October, it's been 365 days since I've missed.
Oh, wow.
Granted, my volume is a lot less than it was when I was doing the mobile VAT nurse, but my last miss was October 2024. And after that, I haven't missed since. All my central lines, all my mid-thigh fems, all my tunnels, all my PIVs and blood draws have not missed. And that is the goal. And if you're like, no, that's impossible. It's impossible because you're using your vein finder and you're not using the ultrasound.
Mm-hmm.
Like, I will use all the crutches. People are like, oh, that's such a crutch, or this is a crutch,
right,
or that gel tower technique is a crutch. My patients and I are very happy with our crutches. Thank you very much.
Agreed.
And I think we need to stop looking at it like, oh, that's for bitches. No. It's for people who succeed. And the reason why I succeed and the reason why and people are like, oh, I don't believe you. You're lying. There's no way. Like, I don't, okay, maybe my ego has a reason to lie, but I don't care. Like, I will admit happily when I'm wrong because it's great content and people love trolling me. But I can proudly say for a whole year, I haven't had a miss. Now, it's only because I have the ultrasound and I've accepted my limitations and I move slow and I use all the crutches I possibly know. I use all the tools I have, all the tricks that I can to make sure I don't ever miss on my patients. So I think it's possible and we need to start seeing that. Now, my objective, because it's so easy not to miss, my objective is until end of treatment. It's reaching the heavens. Every single insertion needs to stay until he or she is done with the treatment. And so far, I have not been able to get 100% with that.
All right. Well, it's good to have lofty goals. My success rate, I track everything that I do. I have a spreadsheet. I do it month to month. I track midlines, ultrasound guided IVs. For the last fiscal year, 177 attempts, 170 successes for a 96.05% success rate. So I'm mad about the 3.95% that I missed. More than a couple of those are my fault. Like I missed something or I didn't advance it right. So, and those are all opportunities to learn. So.
Even if patient was in pain, like what could you have done? So you said you were mad about it. What could you have done to improve the success of that insertion?
I could have asked for additional help to hold that arm steady. because I did not, like you were talking about very early on in the podcast, assessing your patient. Are they going to tolerate this well? And that was where I failed to recognize that this patient most likely will not respond well to this. Now, the numbers that I can see, and I looked up, like, what is the national average? There aren't like solid data on this, but I saw a couple studies that were like 80%. And I thought that's incredibly low. If you're using ultrasound, it should be way higher than that. So I feel like 96 is acceptable, but I like that we need to aspire for 100%.
Was it a pediatric, a confused patient? Like,
yeah, it was like
it
was a dementia patient who was combative. They got sent from like a nursing home where they became combative. I think they had like a UTI that was exacerbating their confusion, and so they were not responding well to that. So yeah, that's typically where I fail, is in patients like that. The alert and oriented patients typically do pretty well. Like, I prep them for it, but yeah, it's that those 6 are going to bother me.
Well, now you collecting the data has now allowed you to dissect the problem. And now you know what the solution is. Now you know, okay, I've smelled this before. I'm just going to get a holder because I want to get up to 100.
Yep. So far for October, I am 100. All right. So I have one more question for you. If you had to stop what you're doing, no more healthcare, you couldn't do anything healthcare related, and tomorrow you had to start a whole new career, what would you do if you had to start all over tomorrow?
Too easy. Medical missions in Guatemala or Haiti.
Okay.
Right now, Haiti's too hot, so I had to stop going, but I'd probably set up shop and figure out how to logistically provide resources and make it sustainable in Guatemala.
That's awesome. I absolutely love that. Thank you so much for taking time out of your schedule and sharing your knowledge and education with the listeners here. I greatly appreciate it. Please tell everybody how they can find you and where they can learn more about what you do.
So you can, any handle, every platform, it's TheVascularGuy. It'll be me with it'll be a black silhouette picture. You'll see that there. You can email me at TheVascularGuy@gmail.com. Feel free to DM me. Every DM that I see, I try to respond to. And you're more than welcome to reach out with like, hey, look, this didn't work out. I can't figure out why this is happening. I may not have the answer, but most likely I will. And I'm happy to be your phone a friend when you're in a pinch.
So thank you so much for coming on. And I look forward to seeing what else you come up with in the future.
Thanks for having me.
Thanks for listening to Beyond the Call Light with Gary Cope. Don't forget to clock out.